followed by preparing for findings. The health history interview is a conversation with a threefold purpose: to establish a trusting and supportive relationship, to gather information, and to offer information. You'll record the patient's chief complaint along with common or concerning symptoms. Common or concerning symptoms relating to the general survey and vital signs include fatigue and weakness, fever, chills, and night sweats, and changes in weight. Good opening questions regarding changes in weight include:
how's your weight compared to a year ago?
I probably gained maybe about 5 pounds.
And why do you think your weight has changed?
Probably my eating habits aren't as regular as I'd like.
What would you like to weigh?
I think right around 180 would be ideal.
Like changes in weight, fatigue and weakness are nonspecific symptoms with many causes. Because fatigue is a normal response to hard work, sustained stress, or grief, try to elicit the life circumstances associated with it. Fatigue unrelated to such situations requires further investigation. Fever refers to an abnormal elevation in body temperature. Fever has many causes. Ask about fever if the patient has an acute or chronic illness. Focus questions on the timing of the illness and its associated symptoms. Become familiar with patterns of infectious diseases that may affect your patient. Inquire about travel, contact with sick people, and unusual exposures. Also, ask about the use of any medications which may cause fever. Before you begin the physical examination, take time to prepare for the tasks ahead. Organize your examination around 3 general goals: maximizing the patient's comfort, avoiding unnecessary changes in position, and enhancing clinical efficiency. Before you actually begin the examination, you will need to determine its scope. This means choosing whether to do a comprehensive examination or a focused examination. In a comprehensive examination, the clinician assesses all the body systems, from the general survey and vital signs through the nervous system. The assessment becomes a source of fundamental and personalized knowledge about the patient that strengthens the clinician-patient relationship. The information obtained provides a more complete basis for assessing patient concerns and answering his or her questions. In a focused physical examination, the clinician selects those methods relevant to thorough assessment of a specific or targeted problem or concern, such as a sore throat. To help determine the scope, consider the patient's symptoms, age, and health history within the context of your knowledge of disease patterns. As a general principle, a new patient warrants a comprehensive examination regardless of chief complaint or setting. Certain measures can help the patient feel comfortable and relaxed. Before starting the examination, close nearby doors and draw the curtains. Concern for the patient's privacy and modesty is essential and must be ingrained in your professional behavior. Before examining each and every patient, be sure to wash your hands in the patient's presence. Adjust the environment and lighting so that both you and the patient are comfortable, and so that environmental factors enhance the caliber and reliability of your physical findings. For example, take the time to adjust the bed or examining table to a convenient height. Ask the patient to move toward you if this makes it easier to examine a region of the body more carefully. Proper lighting not only enhances patient comfort, it also facilitates many aspects of your examination. For example, tangential lighting is optimal for inspecting structures such as the jugular venous pulse, the thyroid gland, and the apical impulse of the heart. As shown here, tangential lighting across body surfaces throws contours, elevations, and depressions into sharper relief, whether they are moving or stationary. Your concern for the patient's comfort will continue throughout the actual examination. While you are performing the physical assessment, keep the patient informed about the areas you are examining, especially when you anticipate embarrassment or discomfort. Drape the patient with a gown or draw sheet to expose only one area of the body at a time. This allows you to focus on the area being examined and is an important measure for preserving the patient's modesty. Be sensitive to the patient's feelings and physical comfort. As you move through the examination, watch the patient's facial expressions. Don't hesitate to ask,
Are you okay? Are you having any discomfort?
I'm fine, no problem.
Okay, very good.
Try to gauge how much the patient wants to know. Finally, make sure your instructions to the patient at each step are courteous and clear. Using the correct examining position and handedness can avoid many unnecessary position changes, as well as enhance the efficiency of your examination. In this teaching session, we recommend examining the patient from the patient's right side, which is standard clinical practice, even if you are left-handed. Of course, move to the opposite side or to the foot of the bed or examining table as necessary. The convention of examining from the patient's right arises from several practical considerations. For example, examining tables are usually configured to accommodate a right-handed person. Estimating jugular venous pressure from the right side is more reliable than from the left side. From the right side, the palpating hand rests more comfortably on the apical impulse, and the right kidney is more frequently palpable than the left. Another measure that minimizes position changes and optimizes efficiency is to select an appropriate sequence of examination. With practice and experience, you likely will develop your own sequence of examination. A general principle is to move from head to toe. Forgetting part of the examination is not uncommon, especially at first. You may need to go back and check one or two items that you forgot earlier. Examine areas out of sequence if necessary, but do so smoothly. Often you will need to examine a patient at bed rest, such as when a patient is in the hospital. This may dictate a need for changes in your sequence of examination. You can examine the head, neck, and anterior chest with the patient supine. Then roll the patient onto each side to listen to the lungs, examine the back, and inspect the skin. Then roll the patient back into the supine position and finish the rest of the examination. Typically, the actual physical examination begins with a general survey of the patient's apparent state of health, level of consciousness, and mood and behavior, including any signs of distress, such as cardiac or respiratory difficulties, pain, anxiety, or depression. You should continue to assess these characteristics throughout the examination. Check for skin color and any obvious lesions. Look for pallor, cyanosis, jaundice, rashes, or bruises. Consider whether the patient's personal hygiene and grooming seem appropriate to his or her lifestyle, occupation, and socioeconomic group. Keep in mind that these norms vary widely. Observe the patient's facial expression at rest, during conversation, and during the physical examination. Odors, such as the fruity odor of diabetes or the scent of alcohol, can be important diagnostic clues. However, never assume that alcohol on a patient's breath is the sole or even the most important cause of changes in mental status or neurologic findings. Note the patient's preferred posture and whether the patient is restless or quiet. How often does the patient change position? Is there any apparent involuntary motor activity? Does the patient walk smoothly, with comfort and balance? Next, measure the patient's height, weight, and BMI. If possible, Measure the patient's height with the patient in stocking feet. Take this opportunity to note general body proportions and look for any deformities.
Yes.
Step back, please.
Whenever possible, weigh your patient with their shoes off. Remember that changes in weight can accompany changes in body fluid status, as well as changes in fat or muscle mass. Assessment of nutritional status is related to observations of the patient's build, height, and weight. Recently, many government and scientific health organizations have promoted the use of the Body Mass Index, or BMI, which provides a more accurate estimate of body fat than does mere weight alone. More than 50% of U.S. adults are overweight, that is, with a BMI equal to or greater than 25. Nearly 25% are obese, with a BMI equal to or greater than 30. Being overweight or obese is a proven risk factor for diabetes, heart disease, stroke, hypertension, osteoarthritis, and some forms of cancer. So assessing and educating patients about their BMIs are vital steps for promoting health. There are several ways to calculate a patient's BMI. A common method is to calculate the patient's weight in kilograms, then divide it by the patient's height in meters squared. If the patient's BMI is 25 or higher, nutrition assessment and counseling are in order. If the BMI falls below 18.5, be concerned about possible anorexia, bulimia, or other medical conditions. Another option for determining a patient's nutritional status is to measure waist circumference. With the patient standing, measure the waist just above the hip bones. The patient may have excess body fat if the waist measures 35 inches or more for women, or 40 inches or more for men. Other observations related to nutritional status include posture, muscle bulk, mood and alertness, facial coloration, dentition, condition of tongue and gingiva, and the color of the nail beds. As you conduct each new general survey, you should strive to sharpen your ability to describe all the distinguishing features of the patient's general appearance in your write-up. Using your description, a colleague should be able to identify the patient out of a crowd of strangers. Now you are ready to measure the vital signs: blood pressure, heart rate, respiratory rate, and temperature. You can also take these important measurements later as you assess cardiovascular status or the thorax and lungs as part of a complete head-to-toe examination. Taking these measurements early in the sequence, however, often provides important initial information that will influence the direction of your subsequent evaluation. Before assessing the patient's blood pressure, you should take several steps to ensure an accurate measurement. Ask the patient to avoid smoking or drinking caffeinated beverages for 30 minutes before the blood pressure is taken. Make sure the examining room is quiet and comfortably warm. Ask the patient to sit quietly for at least 5 minutes in a chair rather than on the examining table with feet on the floor. Check to make sure the selected arm is free of clothing. There should be no arteriovenous fistulas for dialysis, scarring from prior brachial artery cut-downs, or signs of lymphedema. Palpate the brachial artery to confirm that it has a viable pulse. To measure blood pressure accurately, you must choose a cuff of appropriate size. Cuffs that are too wide or too narrow may give false readings. For example, using a regular-sized cuff on an obese arm may lead to a false diagnosis of hypertension. The width of the inflatable bladder of the cuff should be approximately 40% of upper arm circumference, which is about 12 to 14 centimeters in the average adult. The length of the inflatable bladder should be approximately 80% of upper arm circumference, which is almost long enough to encircle the arm. Now you are ready to measure the blood pressure. Center the inflatable bladder over the brachial artery. Secure the cuff snugly. The lower border of the cuff should be about 2.5 centimeters above the antecubital crease. Position the arm so that the brachial artery at the antecubital crease is at heart level, roughly level with the fourth interspace at its junction with the sternum. Make sure the patient's arm is slightly flexed at the elbow. To determine how high to raise the cuff pressure, first estimate the systolic pressure by palpation. As you feel the radial artery with the fingers of one hand, rapidly inflate the cuff until the radial pulse disappears. Read this pressure on the manometer and add 30 millimeters of mercury to it. Using this target for subsequent inflations prevents discomfort from unnecessarily high cuff pressures. It also avoids the occasional error caused by an oscillatory gap, a silent interval between the systolic and diastolic pressures. Missing the true systolic pressure by underinflating the cuff can cause you to misidentify a lower systolic sound as the systolic pressure. Deflate the cuff promptly. Now, place the bell of a stethoscope lightly over the brachial artery, taking care to make an air seal with its full rim. Because the sounds to be heard, that is, the Korotkov sounds, are relatively low in pitch, they are heard better with the bell. Inflate the cuff rapidly again to the level just determined, and then deflate it slowly at a rate of about 2 to 3 millimeters of mercury per second. Note the level at which you hear the sounds of at least 2 consecutive beats. This is the systolic pressure. Continue to lower the pressure slowly until the sounds become muffled and then disappear. The disappearance point, usually only a few millimeters of mercury below the muffling point, enables the best estimation of true diastolic pressure in adults. Read both the systolic and the diastolic levels to the nearest 2 millimeters of mercury. Wait 2 or more minutes and repeat the entire sequence. Average your readings. If the first 2 readings differ by more than 5 millimeters of mercury, take additional readings. Take blood pressure in both arms at least once. In patients taking antihypertensive medications, or patients with a history of fainting, postural dizziness, or possible depletion of blood volume, take the blood pressure in 3 positions: supine, sitting, and standing, unless contraindicated. In 2003, the Joint National Committee on Detection, Evaluation, and Treatment of High Blood Pressure recommended using the mean of 2 or more properly measured seated blood pressure readings, taken on 2 or more office visits, for a diagnosis of hypertension. For adults, the committee has defined 4 levels of blood pressure. A systolic reading of less than 120, in conjunction with a diastolic reading of less than 80, is considered normal. A systolic reading of 120 to 139, a diastolic reading of 80 to 89, or both, is defined as pre-hypertension. A systolic reading of 140 to 159, a diastolic reading of 90 to 99, or both, is considered stage 1 hypertension. A systolic reading of 160 or higher, a diastolic reading of 100 or higher, or both, is defined as stage 2 hypertension, the highest level. When assessing the heart rate, the radial pulse is commonly used. With the pads of your index and middle fingers, compress the radial artery until you detect a maximal pulsation. If the rhythm is regular and the rate seems normal, count the rate for 15 seconds and multiply by 4. If the rate is unusually fast or slow, however, count it for 60 seconds. To begin your assessment of rhythm, feel the radial pulse. Check the rhythm again by listening with your stethoscope at the cardiac apex. Is the rhythm regular or irregular? When the rhythm is irregular, evaluate the rate by auscultation at the cardiac apex, that is, over the apical impulse. If the rate is irregular, try to identify a pattern by asking, do early beats appear in a basically regular rhythm? Does the irregularity vary consistently with respiration? And does the irregularity differ from these findings in other ways, as in atrial fibrillation? Next, observe respiratory rate. Observe the rate, rhythm, depth, and effort of breathing. Count the number of respirations in 1 minute, either by visual inspection or by subtly listening over the patient's trachea with your stethoscope during your examination of the head and neck or chest. Normally, adults take 14 to 20 breaths per minute in a quiet, regular pattern. Normal oral temperature in adults fluctuates considerably, with the average usually quoted as 98.6 degrees Fahrenheit or 37 degrees Celsius. Rectal temperatures are higher than oral temperatures by an average of 0.7 to 0.9 degrees Fahrenheit, or 0.4 to 0.5 degrees Celsius. This difference, too, is quite variable. In contrast, axillary temperatures are lower than oral temperatures by approximately 1 degree, take 5 to 10 minutes to register, and generally are considered less accurate than other measurements. For oral temperatures, choose either a glass or electronic thermometer. When using a glass thermometer, shake the thermometer down to below 96 degrees Fahrenheit or 35 degrees Celsius.
Open, please.
Insert the thermometer under the patient's tongue. Instruct the patient to close both lips and wait 3 to 5 minutes. Then read the thermometer, reinsert it for 1 minute, and read it again. If using an electronic thermometer, carefully place the disposable cover over the probe and insert the thermometer under the tongue. Ask the patient to close his lips, then wait for the digital readout. An accurate temperature recording usually takes about 10 seconds. Most patients prefer oral to rectal temperatures. However, taking oral temperatures is not recommended when patients are unconscious, restless, or unable to close their mouths. For a rectal temperature, ask the patient to lie on one side with the hip flexed. Select a rectal thermometer with a rounded tip. Lubricate it and insert it about 3 to 4 centimeters or 1.5 inches into the anal canal in a direction pointing to the umbilicus. Remove it after 3 minutes, then read. Alternatively, use an electronic thermometer after lubricating the probe cover. Wait about 10 seconds for the digital temperature to appear. Taking the tympanic membrane temperature is an increasingly common practice and is quick, safe, and reliable if performed properly. Make sure the external auditory canal is free of cerumen. Position the probe in the canal so that the infrared beam is aimed at the tympanic membrane. Otherwise, the measurement will be invalid. Wait 2 to 3 seconds until the digital temperature reading appears. This method measures core body temperature, which is higher than the normal oral temperature by approximately 0.8 degrees Celsius or 1.4 degrees Fahrenheit. A clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care. Your write-up of the physical examination begins with your general description of the patient's appearance based on the general survey, and also will include the vital signs taken during the examination. For a healthy patient, your write-up might include language such as, "Mr. Scott is a man of medium height and weight, who appears healthy, well-groomed, and fit. He was pleasant and cooperative during the examination. Height is 1.8 meters, and weight is 82.5 kilograms, giving him a BMI of 25.4. His blood pressure is 115/70, heart rate 72 and regular, respiratory rate 16, and temperature 98.6 degrees Fahrenheit. To summarize, conducting the general survey and taking vital signs include preparing for the physical examination by planning its scope and sequence and promoting the patient's comfort, surveying the patient's build, mood, behavior, appearance, height, weight, and nutritional status, and checking the patient's blood pressure, heart rate and rhythm, respiratory rate, and temperature.